We're back for the next 10 pages. If you haven't seen the first episode, I go through 10 pages that I got on my cover shift. That is pages 1 through 10. Now we're going through pages 11 to 20. Let's go through it. So page 11 is patient accidentally removed NGT. Please advise if needs reinsertion. Now, this patient was a little bit delirious. They had an inpatient delirium. That's why I removed the NGT. Now, if you don't know what an NGT is, an NGT stands for nasogastric tube. People have it inserted for a variety of different reasons. Maybe they have a bowel obstruction or something like that. Essentially, if the contents of the bowel of the stomach can't move through the intestines, then it builds up and they actually get very nauseous, very sick, end up vomiting, and the nasogastric tube is a tube that goes through the nose into the stomach, sits there and actually drains that contents out. The reason that this patient removed it was probably because they were confused, they were agitated, they're in hospital, they're sick, they've got a variety of different medical conditions, and being in hospital is a very unfamiliar environment. They all culminate in this thing called delirium, which is a proper medical condition. You say people are delirious all the time and it's an off-the-cuff comment, but delirium is actually a medical condition that needs to be treated and properly managed. People with delirium can be a bit confused and it can fluctuate throughout the day. That's like the key component. Now, I went through the file for this person. They were actually not too unwell. They were getting better. They were about to have the nasogastric tube removed anyway because the outputs were very, very low. And essentially what that means is that the nasogastric tube wasn't really draining that much. So what you can do usually is you can just leave it on a free drainage. Essentially that just drains itself, and then you can suction the contents out every 4 hours or so. If that amount that you're suctioning out or draining is tapering down, it's reducing over time. So that probably means that the condition is getting better or resolving and probably no longer needs that nasogastric tube in situ. What you can do then is you can just spigot or block off the tube and you can see how they cope without it. If there's nothing getting drained, then you can probably remove the tube. Now, this was towards the later end of the shift. I was about to hand over and you essentially just need to weigh up the risks and benefits. If there's an acute need to reinsert something or they have a really clear documented plan that they need this tube in no matter what, then I would, no questions asked, just put it back in. But this guy had a delirium that needed to be further optimized. The new team was coming on for the day and I wanted to hand over to them to leave that decision up to them about what to do, because that's the patient that they're managing. Yeah, for this patient, I just left the nasogastric tube out. It was a decision for the treating team to make, and I decided to optimize their delirium first and foremost rather than to reinsert the tube, because the patient's probably just gonna either not tolerate it and pull it out again, or maybe they can get a bit more agitated and that can exacerbate their delirium further. All right, number 12, heart rate 50. Mods expired, please review, and please order APTT at 5:30. So this page has two different parts to it. There's a heart rate mod that has expired. We've already been through a similar page earlier. Essentially, what you should do is you should not just blatantly re-modify the OBS. You need to actually assess each patient individually, especially if you don't know them, if you're unfamiliar with them and their clinical situation. A heart rate of 50 might be abnormal for that person, or maybe they should be improving, or maybe it's sort of changed or whatever. Like, you don't know the clinical story. So assess the patient, have a look at their ECG, see how they are clinically. If there's no change and it's been a stable thing for a while and there's no real indication to do any treatment or anything like that, or escalate or investigate why they have this condition, then you can modify the OBS. But yeah, and for those of you who don't know, modifying the OBS, essentially there's a reference range on nursing OBS charts. They are required to put in values each time they measure the patient's OBS. If they are outside the normal range or limits for that particular measurement, say if a patient has a heart rate of 120, then that is outside the normal range. You need to actually alert the doctor looking after that patient that, hey, this person actually has a heart rate that is outside the normal limits, please review. They don't just tolerate it, and that's why they'll keep paging you or asking you to do something. And either modify. So modification just means the normal range is from here to here, and if someone is like persistently outside that range, then what they would do is you have to log on, you have to sign, and you have to say, well, it's actually okay if a person is slightly higher. So say a patient's heart rate, the normal heart rate range is from 60 to 100, a patient's heart rate is 50, then you say now the normal range for this person in particular, for say 4 hours, for 8 hours, for however long you want the mod to go on for, is from 50 to 100. So if their heart rate is between 50 and 100, then that's normal and you don't have to do anything about it. If it's outside that window, then you need to escalate again. So that's the whole thing about modifying OBS. Now, for this patient, they also had an APTT that needed to be ordered at a particular time. Now, what you have to do, so for an APTT, that's the acute partial thromboplastin time. The activated partial something time. It's one of those measurements one of those clotting measurements that measures how effective the anticoagulant is. Now, this patient is on a heparin infusion. What you have to do is you actually just have to titrate that dose based on the APTT. So these get measured, every so often. It might be every 12 hours, every 24 hours, depending on how much the range has changed. If the APTT is too high, then you need to slow down the rate of the heparin infusion and then recheck the APTT after that in X amount of hours. The APTT for this person was being measured for the purposes of titrating the heparin infusion rate and dose. So essentially what you do is you change the rate, you check the APTT, and you say, well, is the APTT outside the therapeutic range, or the range that it's effective clinically for that patient? And if it's too high, then you slow down the rate and you recheck it. If it's too low, then you increase the rate and then recheck it, and essentially just make sure that it's in the right range. This patient was due for an APTT test at 5:30, so you just order it and then you wait an hour or so for the result to come back, and then you titrate the rate of the heparin infusion after that. That's all you have to do. So yeah, that was a pretty straightforward page. I just reviewed the patient, checked on their heart rate and their ECG, made the modifications because there was no change, and then I just put an order in for the blood test as well. Page number 13, let's go through it. So this patient was diaphoretic. They were complaining of hot and cold flushes. This patient actually had a pilonodal abscess. They were awaiting theatre for incision and drainage of that abscess. Now, they were already on pretty broad spectrum antibiotics. I think they were on an IV tazocin, that is otherwise known as piperacillin tazobactam or something like that. Now, I don't know how to say it. I haven't said that out loud for ages, but yeah, this patient, you're worried that they're going to develop septic shock. This person was febrile earlier that day. You're worried that if they become more hemodynamically unstable, they need to essentially be operated on sooner rather than later. Otherwise, the infection will get the better of the person and they'll actually deteriorate further and further to the point where they might actually not be able to be operated on. So if a patient comes in, they look pretty unwell, they need an operation, then you need to just time it right so that they're not too sick to be operated on, and you actually need to get them to the operating theatre in time before they deteriorate further. So they were clinically not that great. They were on the right treatment, but they were hemodynamically stable. There was a plan already to go for theatre and actually do the operation to drain that abscess that was forming. They were febrile earlier that day, but there was actually nothing more that we could do other than give them fluids, make sure they were on the right antibiotics, and just watch them and make sure they didn't deteriorate further. This condition is also very, very painful, so the main thing you need to get on top of is that person's pain control. If you're having trouble with any pain management and the stuff that you're using is not working for that person, then you don't just leave them and say, well, that's all that I could do. You get the acute pain service involved if you need any advice about pain management, especially for very painful conditions, or maybe they have a complex history of pain, maybe they are an IV drug user, maybe they have chronic pain issues with multiple pain medications already on board, and now they have an acute pain crisis that needs to be managed by the acute pain service because it's very complex management. But yeah, that was that patient. Page 14, just a pretty simple one. Paracetamol charted twice, please review. I don't think I did that much for it. I just deleted one of the orders for the paracetamol. This sometimes comes up. Nurses don't like it because it comes up to give both medications, and if you don't change it, then that it'll keep popping up each time you're, prompted to give a patient a certain medication, and you can't just keep saying like clinically inappropriate or duplicate medication, and it gets very annoying for the nursing staff. So just delete one of the meds that you ordered, or cross it out if you're on paper. That's a pretty straightforward thing to do. Or maybe sometimes two people have charted them and they haven't realized that they want it on one particular dose and not the other. That's probably more urgent, that you need to specify what dose you want given, because it's less concerning for a medication like paracetamol where you essentially only give like 1 gram. But if there's different medications that have multiple different doses about how much to give, then that's more important, that you need to actually clarify what dose you want the patient to receive. So yeah, that page is pretty easily dealt with. The next one, patient back from smoking, please review. So this was a funny one that I got. This patient, I tried to review her earlier in the shift, but she was outside smoking and I couldn't review her. I assumed that her pain was actually okay. I got handed over that they wanted me to look at her pain control, and because she had a condition called pancreatitis, usually those people are managed with their analgesia by the acute pain service. It can be a very painful and difficult condition to manage in terms of that. If her pain was out of control or out of proportion, I would have need to contact acute pain service. But each time I went to review this lady, she was smoking and outside the hospital, and I can't go and chase her. So essentially you just have to, tell the nursing staff, please tell me when she's back. I'll come and see her and see how she is. This patient came back. I actually went to see this person after they had come back from smoking outside the hospital, and they were actually asleep at the time of my review. I didn't want to wake them up. They seemed very comfortable. If I wake them up and I ask them, are you in pain? They'd probably say yes. So if they're sleeping, they're comfortable enough to sleep, I assume the pain was under control. If they woke up and they were still in pain, or they woke up before the end of my shift, then I would have come and reviewed them again. That was actually an interesting one. Pretty funny that, sometimes you're just chasing patients around the hospital. Maybe they're out for a smoke, maybe they're eating or drinking, or maybe they're with like physio or something like that. You need to time your visits to your patients appropriately so you can actually do the proper reviews that you need to be done. There are so many times where I've tried to review patients and they're like, oh, they're at CT scan, or they're at ultrasound, or they're getting moved from bed to bed or something like that. Who knows? Or maybe they're in the bathroom, or maybe they're getting showered. Lots of things happen to a patient at hospital. You forget that they actually are still people who need to live their normal lives. So they still have basic functions that need to be done. And they're getting all this medical attention, not only from the medical team, from the doctors, but also from other people involved in their care. Nurses, physios, social workers, occupational therapists, maybe speech pathologists. Having to zoom out of that lens and you can't see the patient whenever you want to see them is sometimes a bit frustrating, but it's a good realization to have. Page 16, patient is waiting for a script. Can you do as soon as possible? Yes, this was a post-op patient and they needed a script. The registrar was busy doing something else, or maybe they couldn't get hold of the registrar. They needed a script for some analgesia to go home with. It was specified in the post-op orders, but the registrar involved in the case didn't actually chart the medications on a script. So that was delegated to me. So I did that. I printed off a script. It was just for a short course of endone and some other symptoms. To find the person where they were, and they just had finished an operation, and sometimes they go to different parts of the hospital. This person was tucked away at some random area that they have now for the post-ops, about to go home. And yeah, it's like transit lounge. It's essentially a place in the hospital where you either you're coming in and you're awaiting a bed, or you've just come from a bed in the ward and you're about to go home. All right, page number 17. Patient wants to speak to a doctor, please come and see. Now, this page sometimes is not that urgent, or sometimes you actually have to bear in mind how much more information or value you can add to a patient's care, especially if you're involved in a role which is a cover role rather than a treating team role. So when you're on cover shift, if another team's patient actually asks you to update them on how they're going and what their progress is and what their decisions are and what their treatment is, etc. I mean, there's only so much information you can give because you have only literally heard about this patient 2 minutes ago via your page, and now you're asked to give an update on the progress of their hospital stay and the future direction of what's going to happen today and tomorrow and for the next few weeks, etc. Sometimes they ask you like what happened in their operation, and you're like, well, this should actually be the surgeon's job, it's not mine. So you can read through the operation note and summarize to the best of your ability what went on, but for the large details like that should actually be delivered by the surgeon or at least a doctor from the treating team. So these pages are interesting. I mean, I just do a bit of background for this. This patient was actually awaiting theatre. They didn't really want to wait in hospital because I think they'd been fasting all day, and then they got told that they couldn't do the operation that day. So they had to fast again and aim for tomorrow. Now, this patient was a little bit frustrated. They wanted to go home. It was a bit more of a conversation about the risks and benefits of going home versus staying in hospital. You sort of just explain to them like obviously you can't force them to stay in hospital, but there is a clinical need to stay, and you recommend that they should stay and get the care that they have been instructed to get. If they don't, then that's fine, but you need to go through all the risks that they could possibly get if they were to leave hospital without getting the medical care. It can be a little bit of an interesting discussion, especially when patients have had a few negative things happen to them. Maybe they've been fasting for a couple of days. Maybe they have not been told much by the treating team for whatever reason. Maybe they were too busy or something like that. But if there's not communication, then patients can actually get very frustrated and agitated. So it's super important just to, this page is a great reminder about how good communication is in hospital. You can do all the good things, but if you don't tell the patient and communicate that to them and let them say what they feel or hear what they have to say or what they want, then it can actually be a bit like misdirected and misaligned the healthcare that you intend to provide them. So yeah, this is a good page, a good wake-up call to actually just take a step back and actually think, well, what am I doing? Why am I doing it? And how does that actually impact the patient's health? All right, page number 18, very frustrating, very common page, ID approval for IV antibiotics. Now, this page is essentially a failure of the treating team to chart or get approval for their antibiotics. At our health service, you can chart IV antibiotics for a period of 3 days before needing to get approval for more doses of that. Essentially, all that means is that you have to speak to the infectious disease doctor, you get an approval code, and then that approval code gets put in the online order. If you're on paper, I think you do the same thing. I'm not sure, it's usually health service dependent, but this whole thing is for antimicrobial stewardship to reduce the amount of inappropriate antibiotic orders that indirectly lead to antibiotic resistance and everything like that. So antibiotic approval codes are necessary. You can get away with it. You can still give the antibiotics on a stat dose order. So what that means is you can, if they're not allowed to give the antibiotic that has been charted already, you can create a new order, a once-off dose for an antibiotic. Now that doesn't need an approval code, and that's what most of us cover doctors do to get around this, because especially if it's late at night or something like that, 2 a.m, you don't need to call the infectious disease doctor and say, please give me an approval code. That job should be delegated to the day team to sort out, because that is a daytime task. Then the patient can still get the treatment that they need, that they've been prescribed, but yeah, you need to run it by the infectious disease doctors to make sure that that's the right drug to be giving them ongoing for the treatment of that infection. All right, page number 19, unable to sleep, please chart medication. Hospitals are very notorious, hard place to sleep. People don't get a lot of sleep in hospital. Lots of sounds, lots of sick people, lots of things happening. It's very tricky to sleep. I think initially you get almost scared off of saying, well, oh, the risks of benzodiazepine addiction and everything like that. And it's not like it's not a serious thing to get addicted to sleeping tablets. It definitely is, and you need to judiciously use it. But in the acute setting, a short course of benzodiazepines or a different tablet to give someone some acute insomnia relief is indicated. Like, people need sleep to get better, and function and do all their daily tasks as usual, let alone recover from a medical condition. So you think about it yourself, if you're sick, if you're unwell, often the thing that fixes you the most sometimes is the sleep. Of course, you're taking treatment or whatever other medical therapy, and that will aim to treat you and make you better, but you need sleep to actually allow your body to heal yourself as well. So sleep is super, super important. I just chart them a sleep medication, usually start off with some melatonin, and if they need, then you can add on some low dose benzodiazepine to relax them and help them sleep. So yeah, that's what I did for that patient. I'm pretty sympathetic to those people who need some sleep, because you realize how important it is for their medical care. All right, last page. This one said, IV therapy finished. Patient also needs albumin ordered from the blood bank. They had low albumin, which is a blood product. That needs to be ordered on a separate form to the fluid form that you chart. And you need to actually request that product from the blood bank. It needs to be faxed across the order, and then they sent it in, and you need to write it up on a separate chart and consent them, because it's a blood product and everything like that. So it's not as simple as essentially writing up a fluid order. So the areas that I've seen albumin used in are people who have low blood pressure and they've got history of heart failure or other fluid overload conditions. You want to increase their blood pressure without causing them to go into fluid overload and become very symptomatic from that. So it's, it's a mixed thing. That cut out, and then I lost battery and we needed to restart. And since that time, I've got a haircut, I changed clothes. I had a couple of showers, I'll be honest. But let's finish off this video once and for all, because this has been too long. So the main thing for that page is that you really want to do a fluid review after fluid has finished, whether that be, crystalloids like some Hartmann solution, or sodium chloride or a dextrose solution, whatever it is, even if it's like some blood products or something like that. After a fluid has been given to a patient, do a fluid review, assess their fluid status, and then work out if you need to keep giving more fluid, the same rate. Maybe you don't need to give any fluid at all. You have to work out whether you give more fluid, no more fluid, or you need to increase the amount of fluid that's been given. Or do you have to take some fluid off? Maybe you've gone too far. There have been occasions where people have just been charted bag after bag after bag of fluid because that's what was ordered last time. So, you just keep on doing it. And I mean, if you know the patient, then that's fine, and you actually understand why they're getting fluid in the first place. Their clinical status may be slowly changing. It doesn't have to change like that, and they may actually be indicated to have intravenous fluids. Maybe they've got like a really slowly improving condition or something. Maybe they've just been waiting for a surgery for a couple of days. Whatever the situation is, as long as you know the patient and you think, oh, I'm giving this fluid for a particular reason, then that's completely fine. But if you're just blindly giving fluid out, that's just like blatantly prescribing a medication. You're not thinking of the indication, you're not thinking of the benefits and the adverse effects of that medication on the patient. So consider each time you give fluid, the same way you consider each time you give a medication. What's it for? Why am I giving it? And how is this going to benefit the patient more than if I don't give it at all? When you do that, then fluid prescribing will actually be a breeze, and you will, well, maybe not a breeze, but I mean, you'll get really good at it. And this patient was still a little bit dry. We gave them some more fluid. We also gave them some albumin, and then, yeah, we just waited for that to happen. By the time that all got sorted, I had finished my shift, and then, yeah, I'd left. So then it's to the home team to review. And in the handover, it was to fluid review that patient. So yeah, that's just the way that works. Anyways, we've finished 20 pages. Hopefully that gives you a better idea of the types of questions or pages that you may get asked on the ward as a junior doctor. There are so many different things. I mean, like 20 pages does not even scratch the surface of how many different questions I've been asked while I've been working on the ward as a junior doctor. So many to go, so many to do. The best way to level up and get better at it is simply rock up to work each day, hold the pager, answer them, ask questions, and you'll just become a much better problem solver. Even if you need to ask advice from someone senior, that's fine, but you'll have your own ways of working out how to tackle that problem. Until next time, we will leave it there. So hopefully that helped. Bye.